I'm Cynthia Bauer in the Office of the Associate Director for Communication. I coordinate the health literacy and clear communication activities here at the agency. And welcome to the OADC-sponsored lecture on health literacy and public health. I'm very pleased to welcome Dr. Rima Rudd from the Harvard School of Public Health, where she is a senior lecturer on health literacy, education, and policy. I won't go through Rima's extensive biography, but I do want to call attention to the fact that even though this is not Rima's first time at CDC, she does have a lot of firsts in health literacy. First health literacy class taught in a school of public health, which she's been teaching since the mid-1990s. She was on the first Institute of Medicine Health Literacy Committee. She also wrote the first Health Literacy Action Plan for Healthy People 2010. So we're very, very pleased to have her here today to talk to us about health literacy and organizational capacity, and we hope to have time for a few questions at the end. So welcome, Rima.
Thank you. It's really delightful to be here. What Cynthia did not mention is that she and I have been working together since 2000, and when she pressed me into government service, meaning a lot of very exciting work and no pay. But we've been working together ever since in health literacy, and it's really been a pleasure. So it's sometimes hard to differentiate where ideas originated or how they flourish, but the interaction and the dialogue continues, and I just find it extraordinarily rich and very exciting. So I've been asked to really talk not in depth about health literacy details. Actually, you have some wonderful things online here. And training programs, newly listed training programs on writing, speaking, looking at numbers and working with numbers and concepts, and working with displays, charts, graphs, and lists, and so forth. So the details of health literacy per se, whether it's 101 or 202, is very much available to you, and I would assume some prior knowledge. But I've been asked instead to really give a bit of an overview of the field and really focus more on where the field is now and what the focus of attention is right now, because there's been a very dramatic shift over time. Let me make sure I'm going to use the right little notes here to move forward. So just by way of background and relatively briefly, health literacy field really began in the 1990s, full force, with the publication of findings from the National Adult Literacy Surveys. So the 1992 NALS, the National Adult Literacy Survey, which was a rigorously rigorously developed survey of adults with an N of over 26,000 in the United States, focusing on adults only, ages 16 to 65. Not a school-based test. These interviews were done in home settings, well over 90 minutes. And they focused not on reading comprehension, that kind of school-based literacy test, but really looking at how people use the written word. So you might be given materials, whether it's an editorial or a sports page or a bill in a restaurant to try to figure out a tip, and you were asked to undergo a task that would normally accompany that material. So if it was a deposit slip, you were also given 3 make-believe checks and you were asked to fill out the deposit slip. So it was using materials as you would in everyday life in order to accomplish everyday tasks. And over time, the adult literacy surveys got a little bit more sophisticated. So it moved, for example, from a focus on literacy, working with prose, working with documents, working with numbers, to a more conceptual notion of working not just with numbers with basic calculations, but math concepts, and looking not just at accomplishing mundane tasks, but doing some problem solving. So the tests themselves, the assessments themselves, increased in sophistication over time. In the 1990s, 1994, the IALS, the International Adult Literacy Surveys, these surveys were conducted in 22 industrialized nations. Obviously, obviously using materials from their own country in their own language. Any countries that had more than one legal language, people had an option about what language to take it in. So in Canada, you had an option between French and English. In Switzerland, you had an option French, German, and Italian. So it used the legal language, it used materials from the countries. The materials were well calibrated, looking at the level of difficulty and sophistication, and the skills were widely published and widely used. So the most recent one was done in 2012. From the very start, the people most interested in this and the people launching the surveys were really educators and economists, because they were very interested in looking at people's ability to fully function as citizens and as workers in the sophisticated world of the industrialized nations. Skill levels were ranged from 0, not working with the printed word at all, to 500. And again, it was economists looking at the demands of the workplace and educators looking at the demands in society in general, who together made a decision that the score of around 275, that mid-range, was the minimum that people needed to really function in an industrialized nation, in their society. Below that was problematic. And below that meant that people had difficulty using the printed word or numbers with accuracy and consistency. So I just wanted to give you that baseline first, and then let me just give you the most recent results from the 2012 survey that was done. And you see where the United States fares. Those countries in black bold are scoring above that minimum range. Those countries in black regular print are on that borderline, about on that edge. And those countries highlighted in red print have problematic literacy skills on average in their population group. Now that average varies from one country to another. The United States, for example, you won't see a normal curve. You see a little bit more like a barbell. So we have a cluster of people at the high end, and we have a very large group at the lower end of that scale where people do indeed have difficulty. We don't fare very well. Over the years, the United States scoring has been relatively consistent. In Canada, which looked like the United States in 1992, scores increased. They invested a good deal more over that 10, 12-year period in adult education. So you saw changes and you saw shifts. Not all countries participate in all waves of these assessments, but for those that do, you've seen some shifts with decreases and with increases amongst a variety of countries. So that average score indicates that there are a significant number of adults in most industrialized countries, by the way, not the northern countries, where the literacy is relatively strong, but a majority of adults in most industrialized nations have difficulty using the printed word with accuracy and consistency. Doesn't mean that there's high rates of illiteracy. That's very different. But using the printed word with accuracy and consistency. And there are profound implications, and the reports really go into detail. They're really well worth looking at, about a sense of agency, a sense of voice, a sense of confidence, participation in civic society, voting, for example, or not voting, economic policy, the job market, job availability, and because a number of us were involved early on and insisting that some measures of health be included as well, there are profound implications for health. And again, those findings are available on the U.S. Department of Education website, on Statistics Canada, and at the United Nations in OECD, for OECD countries. That really spurred health literacy work in the early 1990s. Now, some work had been done before that, most of it international, looking at child health, for example, and the literacy level of their mothers, and there was a very, very strong correlation between the two. So there had been a number of studies done in third world countries, for the most part, looking at maternal literacy and child health outcomes, but not much work done until the early 90s in industrialized nations. So the question that really came to mind once these publications were available for people, it takes a while before we read in fields other than our own, but these findings actually generated headlines in newspapers, as did the 2012 PIAC study, that it was very shocking that the literacy skills of adults, on average, these are high school graduates in the United States, are much lower than we had ever thought they were. And for those of us in the health field who were paying attention to these findings, the research questions were are there health consequences? Now, we saw some indications of health relationships in the analyses that were published. So people with lower literacy skills tended to be from under-resourced areas, tended to be poorer, for the most part, tended to be members of minority populations rather than the majority, tended to be more rural. So you saw the social factors at play, and they also tended to report poorer health on the health scales that were offered. The research that began in the late 1990s, the beginning of the health literacy research inquiry, answered the question with a very strong yes, that we were able to see rigorous studies, differences in knowledge. Some of them were, for example, in the early years in HIV, knowing about your disease, knowing about various aspects of your symptoms, action, taking action such as health promotion and health preventive steps, going for screening and so forth. We saw differences between groups of people who had high literacy skills, groups of people with low literacy skills. We saw it in management of chronic disease. That was really the most powerful findings. The nice thing about studying health literacy and working with chronic disease management is you could very often document and see hard outcomes. You can see changes in glycemic control. You can see differences in glycemic control amongst people with high and people with low or limited literacy skills. Reported health status, morbidity, and mortality. So I dropped the graphic here, but there was a report that was commissioned by AHRQ to really look over the field and report on the findings across the field, whether or not these were rigorous studies, whether or not the findings were strong. The Institute of Medicine looked at this as well, and the answer was yes. The focus was on measuring individuals with some questionable measures, I must point out, because they were not the 90-minute interviews of really looking in depth at people's literacy skills using prose, using documents, using numeracy. They were approximation of reading skills. But even those somewhat weak approximation of reading skills were able to separate out two different groups of people with high or more limited literacy skills. And indeed, we were able to conduct research studies based on the use of those measures. The findings, as I mentioned, for the most part, were looking at preventive activities, but those were reports, looking at management of a chronic disease, and that's where we had some of the strongest measures. The research had gaps. At the beginning, they only measured reading skills, or approximation of reading skills. It was only maybe 5 or 6 years ago that people started paying more and more attention to math skills, and not just quantitative skills of adding, subtracting, multiplying, dividing, but looking at math concepts. And here is where the issues for public health became even more profound, because we were looking at abstractions, at concepts that we very often take for granted but never explain. We'll talk about normal, but we don't explain what that means, what normal means. It's a word we take for granted. Range, risk. All three of these, for example, are highly sophisticated mathematical concepts that we take for granted in our use of those terms, expecting people to make decisions or actually take action based on those concepts, but we don't explain it. And as a matter of fact, there was a study done several years ago amongst medical students in the United States asking them to differentiate between absolute and relative risk, and they were not able to do so. How then are they communicating risk to their patients over time? So again, things that we very often take for granted are something that really came out of this research. And so people are now trying to fill those gaps, pay attention, for example, to math. But the other aspect of literacy, when educators talk about literacy, they talk about 5 linked skills: reading and writing, speaking and listening, as well as working with numbers and mathematical concepts. And it's the speaking and listening that we've been very slow to be attentive to as well. And here again is the core of public health. It's often the core of what's going on at CDC. We have alerts, we have warnings, we want to communicate, we want to talk with, not just to, the public. And all of these literacy skills are very highly linked. So it's only recently that you're seeing the emergence of studies, I would say again over the past 3 years or so, that are looking at literacy in terms of speaking and listening skills. Those are new developments. And then I want to talk to you about a couple of other new developments that I'm going to illustrate. Now, the research in health literacy, in a sense, reached a brick wall. There was a problem that emerged. One was the definition of terms, where we looked at literacy almost as an attribute or characteristic of an individual. You have low literacy skills, you have high literacy skills. It's something that you own, that you have. We always knew they were malleable. We could work with people to improve their literacy skills, but we focus on literacy as a characteristic of an individual. That was the focus of our attention, and that's what we were measuring. The problem is that if you then see that there are a group of people with limited literacy skills who have bad outcomes as far as their diabetes or hypertension or their ability to control asthma or their children's asthma, what do we do about it? We, of course, are not educators. For the most part, we're not adult educators. We don't teach in the K through 12 system. We're not going to increase adult skills. So the conundrum that happened was that we didn't know what to do as far as a change strategy is concerned. Our change strategy could not be, well, we'll wait until education improves, and then we'll talk to people a little bit more, and it'll be clearer to them. So there was a problem there about what to do about this. What we never asked at the beginning, and the first at least 15 years of health literacy studies, is we didn't look at the role and responsibility of health professionals and health institutions. So we didn't look at other key variables, and that was a clear error that was made. So health literacy limitations, we had a narrow scope of inquiry. We focused on the deficits of individuals. We had faulty and narrowly focused measurement tools. Reading only, we didn't do math until a while later or look at other aspects. We're only now looking at speaking and listening skills. And there were no measures developed for other key variables. So I'm going to give you an illustration by way of a game. How many of you, just by show of hands, have seen this before? Sorry about that. But if those of you who haven't, if you wouldn't mind, if you can just jot down these 9 dots. And the challenge is that you have to connect those 9 dots, all of them, with 4 straight connected lines. So once you begin, don't lift your pen from the paper. Connect all the dots. Okay, let me just show you the results. There's line 1. There's line 2. There's line 3, there's line 4. I've connected all the dots. Now, unless you move in that direction, you'll miss a dot. You can't do it. Our tendency, unfortunately, is to think within the box. Because once we see those 9 dots lined up, it forms a kind of box in our mind, and the difficulty that we have in connecting all of those dots is that we stay within the box. This is what happened with health literacy. The focus was on the individual, the citizen with limited literacy skills, the average high school graduate in the United States. And because we're focused on the individual, we developed tests and measures that measured the skills of individuals. And then we linked the skills of individuals to health outcomes. And there's a scientific logic to all of this, but it left us without an action plan, and we didn't know what to do about it. And indeed, we left out key variables by doing that. So from the literacy field, we have insight in regard to this, that literacy is context specific. If you're going to accomplish a task where you have all the time in the world, you're very often going to get it right, even if it's a difficult and complex task. You'll have time to mull it over, you'll ask for help, you'll ask for insight, you'll think about it. But if there's time constraints, very often people will make errors, will make mistakes. But literacy skill assessment must also consider the other side of its own coin. So you can't measure someone's reading skills unless you know something about what it is that they're reading and the difficulty of what they're reading. You know, if we go back a century in this country, when one had to pass a literacy test in many parts of this country in order to vote, the literacy tests that were given to white Americans was very different from the literacy test that was given to Black Americans. And there's documentation about this as well. They were more complex, difficult text, and often degrading text that people were forced to read or had to, test on. The context is important. The text is important. So you cannot say something about someone's listening skills, for example, unless you know something about the clarity of the speaker. So you have to measure both sides of the coin, and we weren't doing that at the beginning of health literacy studies. So the difficulty of the task wasn't included in the analysis, nor were there constraints and facilitating factors in the context. There's also insight from our own field of epidemiology. Epidemiology has always insisted on the reciprocal relationship between persons and their environment. So if you're looking at the literacy skills of a population group, you have to look at the context within which they're functioning. Extraordinarily important as well. Health literacy findings, there was one stream of research that was not given a good deal of attention for a very long time or a good deal of respect. It seemed much more powerful to launch a diabetes study and to look at people managing their diabetes and measure glycemic control. Those kinds of articles were a little easier to publish as well. Then were the more mundane articles that were looking at texts and talk in communication studies. And yet that field was growing, that area of research was growing. I wrote here well over 1,000 articles because I haven't counted them for quite some time. But from what I've been able to look at, there are well over 2,000, perhaps even 3,000 articles in peer-reviewed journals now that are looking at the texts and tasks in a variety of health fields. And looking at the documents themselves, the materials themselves, and the difficulty or ease, the complexity or simplicity of those materials. And for the most part, all of the findings are in line with each other. That we're writing texts, we're writing materials, we're describing messages, we're giving people instructions and directions that very often are poorly organized, are not logical, are using vocabulary that is way out of the of everyday life and everyday use. So our materials are woefully inadequate. They are not, it's not that they're sophisticated and the public is unsophisticated, but there is not a meeting point. They are just not talking to one another. So whether you're looking at readability or the match or suitability or usability, which is extraordinarily important, it's not there. We've known this now. This literature is growing. The literature actually started in the 1960s, looking at package inserts for drugs and other materials. And who in the world the pharmaceutical companies at that time were writing for was not clear, because even clinicians were not able to really make good sense out of what was being said there. So the first line that goes outside of the box and goes away is that line that tells us we must pay attention to this part of the equation as well. We must pay attention to health materials and tools that we ask people to use and that we assume that people can use with ease. a peak flow meter, a glycemic measure. Even making sense out of all the different measurements that we have for the body. Blood pressure doesn't correlate in any way with blood sugar level. We're using different scales, we're using different numbers, and we're not making very good sense of it for the public and for the public communication. Research analysis also tells us that we have to do a little bit more than simply focus on the patient. And it took a long while for those of us in health literacy studies early on to look in the mirror. So a lot of attention was being paid to your literacy skills, to your ability, and your working with math. And the mirror wasn't right in front of us saying, well, what are my communication skills? How well am I explaining this? What vocabulary am I using? How well am I giving explanations for the sophisticated math concepts that I expect people to use? So it took a while for people to look in the mirror. But we addressed this and talked about this in 2003 in the Communicating Health report that I worked with Cynthia on, the Institute of Medicine report in 2004, a report and analysis that I did of health literacy of U.S. adults in 2004, and the National Action Plan of 2010 as well. We talked about this many times, and yet the message isn't quite clear. But this is the other leap outside of the box that we must take. We must look at professionals' rigor and skills, the ability to communicate. And people are doing more and more of this. So I was a participant on a committee amongst a group of melanoma lab researchers. It really was very difficult for me to quite understand exactly the work that they were doing. It was much more sophisticated than I was capable of understanding at a meeting. But their dilemma and their difficulty was that they had very important discoveries and very important developments, but they were not communicating with clinicians. And clinicians were not making use of their findings. Let alone clinicians were not speaking to their patients about something that they themselves didn't understand. And it was the scientists who really brought this meeting and brought many outsiders to the table because they were not communicating well. They had this exciting result and exciting findings, but they were not talking in a language that could allow research to move into practice. We're seeing a lot of attention being paid in medicine. So a number of medical schools, for example, have incorporated health literacy in their training, teaching doctors how to use something called Teach Back. It's a way of testing the clarity of your communication. So you're seeing some changes taking place there. For those of us in public health, we've long had an emphasis on the written word. We haven't had as much of an emphasis on the spoken word. We haven't paid enough attention to the explication and explanation of concepts. So we too have not been paying as much attention as we could have to what the findings mean in health literacy and how we might change the work that we do. The next area of work takes along a shift of responsibility. You saw a reaction in medicine when it seemed as though, okay, we were beginning to take our attention away from a focus on the patient, and the patient has skills or has deficits, and we were now looking at the communication skills of the clinician, and the clinician needed to change his or her practices. But that was also an undue burden of responsibility that we expected a clinician to take on. So what you heard more often than not is, I don't have time. We have 11 minutes to see a patient. I can't go into this level of explanation. It took a researcher like Dean Schillinger to show that using Teach Back, for example, as a technique for checking clarity did not add to the burden of the time period in the visit. And yet it had other benefits that were well worth doing. So there were studies that were launched that countered some of those arguments, that shift in responsibility. And so that then was saying, well, maybe there are other things that we need to look at rather than just the worker, the communicator, the clinician. And perhaps we need to look at the environment within which they're working. So this is really the new development that's been happening for the past several years, although it's always been part and parcel of our work and our focus for a number of us in health literacy studies. So moving from the Institute of Medicine report, going along with the idea of looking at health literacy as a national action plan. The Joint Commission also looked at and started linking health literacy to patient safety. We are looking at the health literacy environment within which people are working. So what are the environmental constraints? It's not just time, it's practices, it's norms, and this has really become the new focus of attention. We're still obviously wanting to improve communication with the individual, with the population, with the community. But in order to do so, we're realizing that the shifting of responsibility is a key factor in our work. So at first, the burden of responsibility seemed to be on the shoulders of the citizen, then on the shoulders of the clinician or professional, and now people are looking at that interplay that really takes place working with and in institutions. So institutional norms, policies, and practices that either limit or facilitate the ability of workers and professionals to really follow through with what they know science is telling them that they need to do. So in looking at healthcare institutions, this is becoming a very important moment. Now, what can I say about Centers for Disease Control, where you are working in your institution? Most of this work was really focused on healthcare institutions. So it's only now that a few of us are really beginning to look at public health institutions, whether they're something like the Centers for Disease Control, or whether they're regional or state or local public health. What can these institutions do? What are the characteristics of these organizations that either impede or facilitate communication with the public? Now, Cynthia Bauer has listed up on the CDC Health Literacy website the beginning of looking at organizational attributes, taking a lot of it from what is defined for healthcare institutions, but we, as a field, need your input on this, because this is new. Do those attributes resonate with you? Are there other things that you'd want to highlight as far as working here, for example, at the Centers for Disease Control? What are the attributes of a health literate organization where we're putting into play everything we know about population deficits, everything we know about good communication, and everything we know about what makes literacy difficult or easy? How do we ease the burden? So this is worth looking at and thinking through about one's own organization. How do we change an institution in order to increase capacity for communicating well and improving communication with the public? We have to analyze the current situation. What are the practices? What are the norms, our behaviors? What are the sanctions in play for violations? And what are the policies in play? And how do we go about making transformations as such so that our work could be efficacious work coming from a scientific base, and how do we change it? It might be the easiest thing might do to change contractual language when we're making contracts with people who are outside. They have to follow certain rules and regulations that we set into play that integrates the best of what we know about communication practices and health literacy practices. But how do we change the policies and norms within our own workplace? Is a very difficult challenge to undertake. But it's very important to do that. So our focus, in a sense, on all three of these triangulated issues really helps lead us to this point of effective communication. I took a long time in dealing with that metaphor, but that metaphor of working within the box and working outside the box has been resonating with me recently. So as we saw a shift in focus from looking at skills of individuals to beginning to look at not just their skills, but the match or mismatch between what we offer people and what they're capable of understanding and comprehending, as we shift our focus from looking at the citizen, the public, to looking at professionals and staff, and as we shift from looking at staff alone as though they were isolated units to looking at the institutions within their work, we need better definitions of terms, we need better measures. I can't tell you how many articles there are out that are looking at yet a new measure of someone's literacy skills, yet again, a way of measuring the deficits of the common citizen. But there are no measures and tests out there to measure a doctor's communication skills. Very interesting. Is it too challenging? Is it too threatening? Is it too difficult to do? We haven't developed measures. We haven't developed really concrete measures to look at institutional characteristics either, although there's an attempt now to get this in motion and to do this. This is, by the way, is not just happening in the United States. This has garnered a great deal of attention in Europe and Australia and New Zealand as well. So there's a whole movement afoot to be able to look at and identify literacy-related barriers, access to information and access to care and access to services. So it is time for action. We've documented the literacy and numeracy skills of the public in at least 30 industrialized nations. We have documented links to social factors that shape literacy. It's documented links between literacy and health outcomes, even more powerful than education, because the foundation of education is really literacy. A documented mismatch between the average skills of a population group and the average demand of health information and health messages and health tools that we give people. The implications are profound health disparities. And one of the charges, obviously, of Centers for Disease Control is to reduce disparities. So it fits very well with the work that you're doing. So the new research question that really faces us in health literacy is, how do we increase organizational capacity? How do we go about doing that for shaping messages? Many people are turning to anthropology or sociology. There's a long tradition and a very powerful history about looking at organizational culture, corporate culture, the same as looking at any other culture. All of us, we have, if we're working within an institution, there are values and a vision, assumptions and beliefs like the primacy of science and the importance of scientific inquiry, very much part and parcel of work in epidemiology. There's a language, it's very often a language that grows within a culture that is sometimes indecipherable to people outside of that culture. We sometimes call that jargon, but it is a specialized language, and sometimes it's filled with shortcuts that only people within that culture can understand, can fully grasp. There are rituals and procedures, there's a power structure and a hierarchy, and there are both norms and rules. And so as we analyze our own institutions, we can analyze our institutions along these lines of an anthropological analysis so that we can understand and look in the mirror and see what our own culture is and what constraints might exist within our culture. An easier way for me of looking at this goes back to Kurt Lewin, who is often considered to be the father of behavioral sciences. And Kurt Lewin talked about a force field, that if you're going to analyze any situation, you have to understand that a situation stays the way it is because there's an equilibrium that has been established. And within that equilibrium, there are always some forces for change. There are always some forces that counter change, and that balance is established. But if you want to bring about a change, then there's a difficulty here, because you can identify both those barriers, forces resisting change, as well as those facilitators, forces supporting change. So we want to change or shift that equilibrium. And Kurt Lewin's research pointed out that strategy is very important here, that a common strategy, and it's something that almost comes instinctually. You know, we want children, this is when I was much younger and working, looking at smoking behaviors, for example. We want young adolescents to not smoke. So let's scare them. Let's bring in those dirty lungs into the high school classroom and really have terror in their heart and show them what's ahead and push them in the direction of stop smoking. But what we didn't pay attention to was some of those barriers. Maybe it was cool to smoke. Maybe all of your friends smoked, and if you stop, you're outside of this group now. And we weren't paying attention to those issues. So as we begin to push people, because we want them out of this room, and as we push them towards that exit, Kurt Lewin pointed out the first thing you have to do is, one, before you push, make sure that door is open, because otherwise you're just going to bang their head against a locked door. And so the strategy that came out of Lewin's work and Lewin's force field analysis was, in order to think about action, you first must remove barriers. Then you strengthen the facilitating factors. Then you reestablish an equilibrium with a new norm. So to do this analysis of how to change the culture here, we must look at those existing barriers as the first order of action. Now, let's look at some of the barriers. So one is a barrier of misplaced rigor. The argument is that we must stick to what we're doing for fidelity reasons, that science requires precision and it requires the precise and accurate word. Lessons from health literacy tell us that words get in the way. Jargon is a barrier to understanding. And the notion of clear communication, the notion of universal precautions with our communication and language is to make information accessible to all. Another barrier is a kind of hierarchy of value. There's a primacy and outcome research. Years ago, when I was doing inquiry in the 1990s about social marketing, people in the commercial sector were pointing out that we in the commercial sector, we do research in order to know. We test our ideas, we test our concepts, we test our products before they're put into the production line, before they're out there for distribution. We don't want to lose money. That's the only way we can make money, as a matter of fact, if we do this very careful testing. Research to know. And they said somewhat dismissively, you people in public health, speaking to me and my colleague who were interviewing, do research to show. You do research at the end. That's where you put all of your sophisticated analyses. And you know, although this is very superficial, there's something right about this argument about what we tend to do. We don't put enough resources in the early part of our work, but we put an awful lot of sophisticated analyses at the end. Any student who enters the School of Public Health for a master's or doctoral degree, the first courses you're taking are biostatistics and epidemiology. So you're learning how to analyze data before you even understand what data are and how data are collected. The analysis is coming first. So we have an undue emphasis here, and perhaps we need to make a correction, because evaluation sciences tell us that there are three aspects of evaluation. All three have their place, have their role, are critical. It's formative evaluation, process evaluation, and outcome evaluation. And if you miss out on doing formative evaluation, your outcome evaluation of success or failure doesn't offer you any explanation as to why you succeeded or not, nor can you make a good attribute to exactly what you did or to the program itself. Now, we've had classics in health literacy for the longest time. National Cancer Institute, Making Health Communication Work, lays out, this book used to be called the Pink Book. It was a Bible. People used to carry it around in communication, of how to do really effective formative research and in communication. Doak and Root book. It is also considered a Bible. And so, too, I use this in my class as well as the CDC Simply Put. I think it's offline now. It's going back online eventually. But these tools exist and have long existed, way back when. With evaluation, how do we judge the success of a communication effort? And here we see communication out my mouth and into your ear. Do we look at clarity and efficacy of my talk? Or we just look at your understanding and use? So again, we're making an error here. So research rigor demands that we do formative and process evaluations first to make sure that the clarity and efficacy is there, one can understand and one can use, and only then do we do the outcome evaluation. Another barrier is information overload, the research to practice failure. I mentioned that with the melanoma example. Sometimes the researchers are indeed speaking a very different language from the practitioners, and communication is not taking place. But sometimes, even when communication is clear, the practitioner is just absolutely overwhelmed by the amount of information and the number of fields. And so that question of why are we not applying scientific findings is a very complex one. Is it clarity of communication? Is there just too much out there and we don't know how to integrate it? Is a real problem. Now, there are many insights that come from the communication sciences. I gave an example of fear appeal. We know that one doesn't generate fear unless one provides immediate solutions. I mean, this is just one well-known and somewhat now superficial finding from communication sciences. But there's a lot of rich information and findings out there that help us shape our communications and our messages. There's a lot of information from literacy analyses where we look at text complexity. How do people use text? What makes it easy? What makes it difficult? How can we modify it? How do we display numbers and concepts in ways that people can grasp the meaning of difficult concepts? How do we analyze the task that we expect people to perform? An example that I'll make note of in just a moment looked at what happened during Hurricane Katrina. Cece Doak, who is about to celebrate her 92nd birthday and is often considered the grandmother of health literacy, and her husband, Len Doak, who died a few years ago. We were all in a meeting around the time that Katrina hit, and the Doaks decided to contact Centers for Disease Control because they formed a group, there were several of us all over the country, of first responders, that if Centers for Disease Control wanted to send out any information from all of those people who were confined in that Superdome, they could send it to us, send it to the Doaks first, who would then send it out to us, and we promised anything from a 6-hour to a 24-hour turnaround time on those materials to make them better and make them more comprehensible. Because in some ways the task analysis, the test analysis hadn't been done before. One of my charges was looking at materials that had to do with entering a home after the hurricane to address mold and mildew. It was not clear. It was not well organized. It had not been tested with a group. Partly we knew this because if you looked at step 10 said to put on your gloves and put the bleach in a bucket, but step 1 never said to bring gloves, a bucket, or bleach. So something was amiss here with the communication. So these kinds of analyses are available to us, but the barrier is that there's a cognitive shift even amongst us who consider ourselves scientists during crisis events. You think about anthrax, you think about Katrina, you think about Ebola. When the unexpected takes center stage, very often rigor is abandoned. And the question is, how do we improve communication in times of crisis? So that barrier of suspended rigor, we really have to counter within our institution, and we have to think about removing that barrier so that there are practices and policies in place that we all are accustomed to, we can maintain rigor with established policies and norms. A facilitating factor in doing this is that there's an emphasis within this institution, part of the mission, on equity and increased access to information. We need to address multiple population groups, the idea of health literacy and the clarity, and the idea of universal precautions, where we're communicating to the largest number of people that we can in many different contexts, is a facilitating factor in our work. Theory and practice come together to help us stick with our guns in regard to asking for policy changes. A health literacy focus enhances public health work, addressing vulnerable populations, and whether we're developing questionnaires in order to monitor and diagnose, whether we're presenting findings and offering measures, whether we're trying to mobilize community based on our findings. It requires the communication of our findings, to enforce, to link, to assure, to evaluate. Every one of these, it doesn't mean that health literacy takes center stage, but health literacy is one of the tools that could enhance all of this work in workforce development. And so one of the strategies to think about is to have a dual focus. We know what the formative research protocol is. For the most part, it's in play, although I learned from some insiders that we often give short shrift to some aspects of it. So we have methods that work in the best of times, and we need to think about not dropping those methods for the worst of times, times of chaos, but how do we modify those methods so that they're workable even under stress, times of short time constraints, times of increased mobilization and a sense of urgency. I have some examples here. My time is a little bit short, so I'm going to have to, I really would welcome those of you who can to stay so that we can engage in some discussion and question asking. These are just some examples of how we might perhaps draw from qualitative research studies, for example, free listing, if you want to find out how familiar people are with a concept. Really only requires an N of 20. It doesn't require a national survey. How do we apply some qualitative methods to still be able to do an assessment, to test ideas, to find out people's response? Do it with rigor, but not be weighed down by what seems like an overwhelming burden of rigorous work that you do in the best of times. So what I was trying to illustrate here, and we're going to show a little bit more in detail in a workshop that we're offering tomorrow, is how do we stick with rigor, stick with the process, make sure that we do a rigorous assessment, that our development is participatory, that we test out ideas and concepts, that we pilot with due rigor. And how do we do this in ways that perhaps can be done in short-term turnarounds? Can we have a group of first responders here? Can we work with people who could look at materials who are the non-scientists on staff? Can we assemble teams with non-professional staff that have the dignity of being active reviewers, but perhaps their job, is on another level? Now, obviously, it requires work with unions to get people time off task, to be able to engage in this very important work. But we have, and you have within this building, people who are from the community who don't have scientific training. Well, they can offer brilliant insight into whether or not a message resonates, whether or not vocabulary and words within a group are meaningful and comprehensible, whether or not their priorities are being reflected. So there are ways of assembling teams and doing rigorous work without the textbook requirement of large numbers and sophisticated data sets. So needed action is we need to define and develop a health literacy environment that supports scientific principles and practices, that's conducive to efficacious action, and that integrates health literacy findings and insights that we really can now bring to the table about communicating with people. I didn't go over the specified time, but I apologize for not leaving much time for dialogue and discussion at this point. Our goal is to establish a balance so that our communication is matching. We're actually talking with people, and I hope that in my talking with you, I didn't rush through it too much, but I did take too much time. So questions and discussion or ideas that you want to bring to the table about organizational structure. You have a little, if you do want to make a statement, this is press to talk. You have microphones, and the use of the microphones would mean that your voice and question is captured on the video and on the audio. You're also welcome to come up to the front and just engage in conversation. Yes?
Good morning. Thank you for the presentation, Dr. Rudd. My name is Steve Luce. I'm from CDC's Division of Human Development and Disability. And you didn't really touch upon this concept, but I do think about this a lot in terms of our current thinking of communicating with clinicians and professionals, health professionals.
Yes.
I remember reading multiple times a couple of years ago about the influx of doctors as English second language and other physician assistants and other health aides. I know we put a lot of focus recently into more English as second language for end users, individuals who need to receive health information, but are there implications or considerations that the newer research or you all are thinking about in terms of English as second language and how that relates to health literacy with clinicians or medical staff?
I think that's an extraordinarily important question, and especially for a country that really is based on immigration and immigrant status. At the beginning of a lot of health literacy studies, there was an attempt to keep culture and language separate from health literacy because looking at the two together made research very complicated and complex, and so they were separate streams mutually respecting one another. However, it is time for that to come together because that is an incredibly important issue. For the longest time, we thought about looking at the culture and language of the patient and putting things into play for the patient, forgetting to look at the culture and language of the clinician and the communication with the clinician group. So I would say that there's not yet a good deal of work in that area, but there is acknowledgement all around that those two somewhat separate fields of work really need to come together and work together. One of the issues with translation, for example, is that translators very often tend to be very highly educated. So someone who is doing a translation from English into another language will very often use a very sophisticated term in translation. I'll just use a simple thing of utilize versus use. So there might be a temptation for the more educated person, the translator, to have the word utilize rather than translate it into a more everyday word like use. So health literacy training for translators becomes incredibly important too. So you highlighted an issue, but there's not very much integrating the two as of now. Another question? Yes, Chris.
Thank you so much for a wonderful presentation, nice synthesis of the work over the years. I'm curious, are you familiar of any organizations that are sort of out front in terms of becoming health literate organizations, or at least reflecting and building change strategies?
Yes, there are a number of hospitals that are on board to become health literate organizations. I can probably find those for you and send you the information over time. There are a number of countries that are focusing on how to really look at this issue of health literate organizations. first picking up from what was done at the Joint Commission in linking patient outcomes and safety with health literacy. And so what is it that we can put into play, what policies and norms? And then looking at the Institute of Medicine report on what constitutes a health literate organization and adopting and adapting that to their work. So there was recently a workshop on this at the Institute of Medicine roundtable, and that report is coming out very soon, so I can also forward that to you as well. But yes, there are a number of organizations that are taking that on. Now, they tend to be in health care.
Okay, that was my...
So what is missing and what we're hoping to mobilize is really intriguing work in defining what is a health literate public health organization. That would be absolutely fascinating. So there's lots of room to make a contribution to that right now. Thank you. Time, I guess, is up.
Please join me in thanking Dr. Rudd. So this presentation is archived on IPTV for anyone on the CDC network, and we hope to make this available as a public video with closed captioning after the fact. So thank you for joining us today.